My name is Thomas Lowe. I am a vascular surgeon practicing in Houston, Texas. Over the past 5 years, DVT and PE care has become a large part of our practice. Our team has performed over 400 thrombectomies in that time. This focus and experience has allowed us to refine our protocols and techniques rapidly. One of the most common questions that we get asked about is what our venous closure technique looks like. This isn't particularly surprising, given that most interventionalists rarely use sheaths larger than 16 French in their other procedures. In this video, we will review the options for large bore venous access closure. We will then review the clinical, operational, and economic implications of different techniques, and lastly, hone in on what our current technique looks like. As always, this should not be considered in any way to be medical advice, and given that every patient's case is unique, techniques and plans should be tailored to the individual. This should serve as an overview of currently available options. With venous intervention, it is common that patients will have a 16 to 26 French sheath placed in the femoral, popliteal, jugular, or brachial veins. When the procedure is completed and all of our other endovascular devices have been removed, we need to figure out how to remove our sheath and obtain hemostasis. For simplification purposes, we're going to consider using the most extreme example, a 26 French sheath, which has a diameter of just under about 9 millimeters, with a skin incision to accommodate this of about 10 millimeters or 3/8 of an inch. We will also assume that the patient is fully anticoagulated with an activated clotting time of over 250. We will consider the effectiveness, complexity, and cost of each technique. We have three different techniques that we should consider. One, manual compression. Two, internal suture-mediated closure. And three, external suture-mediated closure. Manual compression means simply holding pressure until it's no longer bleeding from the access point. It's by far the most common closure technique for small bore venous access, and some providers have described using it on large bore venous access sites as well. It's an effective, albeit not particularly efficient technique. I've heard providers refer to a 1 minute per French size rule for venous access, where the initial pressure is held for over 20 minutes in most cases. While pressure does not need to be particularly hard, this is not comfortable for the patient, provider, or their staff. While some would argue that the cost is zero, owing to no devices or suture being used, it does carry a large time cost for everyone involved. This time penalty can be particularly brutal in busy cath labs and operating rooms. Next, we have the internal suture-mediated closure. At the time of this recording, there is only one device that is FDA approved for large bore venous closure, and that's the ProGlide, or its new replacement, the ProStyle from Abbott Laboratories. After initial venous access is obtained, two ProGlides are deployed at different angles. These are then left alone while the large bore sheath, up to 29 French, is placed over a wire into the access vein. Once the procedure is complete, the large sheath is removed and the sutures are cinched down tight on the vein. I will link a video from Abbott Labs for the full technique somewhere around here. This is a very effective technique which has been described in the medical literature in the context of venous access in elective cases. These demonstrate rapid hemostasis with a low rate of complication. We have found two primary issues with this technique. Number one, because of the per close technique happening prior to the intervention, or as Abbott refers to it as the index procedure, there's at least some delay in performing the intervention. In many cases, this 2 to 5 minutes of delay is likely irrelevant. However, there are situations, for example, in high risk and intermediate high risk pulmonary embolism thrombectomy, where this can be problematic. Some providers have described placing ProGlides after the index procedure so as to not delay the initial intervention. Unfortunately, we have taken multiple transfers to our facility from other places, in which this has resulted in iliofemoral DVT formation, secondary to femoral vein stenosis from improperly deployed ProGlides. The second major disadvantage of this technique is cost. Medical devices depend on the contracts with each individual hospital, but a single ProGlide costs about $700. When using two ProGlides, this can increase the cost of the procedure by 10 to 20%. The third and final technique is external suture-mediated closure. After the procedure is completed, the suture is placed in a figure-of-8, mattress, or purse string configuration around the sheath. I will link to a couple of good examples of the techniques here. The sheath is then removed and the suture is cinched down on top of the skin, closing the skin and the subcutaneous tissue, in contrast to the internal suture-mediated closure where the vein itself is closed. At this point, there are two options. The first is to tie a knot and secure the suture in place. The second is to use a suture retention device, such as a FlowStasis from Inari Medical, which maintains tension on the suture until removed. For the full technique for the FlowStasis device, I will link another video here. Manual pressure is then sometimes held after the suture placement for about a minute or two, but the vast majority of the time, we haven't really found this to be necessary. Here you see a 16 French sheath in a popliteal vein. You see two bites placed on either side of the purple sheath in a figure of eight or Z-stitch pattern. After this is completed, the needle is protected and the first throw of the knot is cinched down on top of the sheath. The assistant then removes the sheath and then the wire in succession. The first throw of the suture is tightened down under a finger to the skin. Subsequent knots are then placed on top and the suture is cut after about 6 throws. I edited this video for brevity's sake. However, from the first needle bite to scissors was under a minute, and you'll notice that no manual compression is held after the suture is cut. We then place a dressing over the suture, which is then to be removed after 24 hours. We tell our patients that the suture will fall out on its own after about 1 to 2 weeks. After over 400 venous access closures, between 16 and 26 French, and no access-related issues, we use this closure technique routinely. I initially used non-absorbable nylon suture for this, as it was what I was using for most of my other closures that required external sutures. However, this added more complexity to the patient's care as it required coordination for suture removal. It definitely is a minor consideration to be sure, but my patients have appreciated not needing this additional step. One of the most common questions we get asked about is how to pick what suture to use. Anyone that has seen the Ethicon catalog and its thousands of sutures and needles understands why it can be overwhelming to try and figure out what to use. At present, we typically use a 3/0 monocrystal suture on a tapered SH needle. The most commonly available absorbable sutures are Vicryl, PDS, and monocrystal. Vicryl and PDS retain their strength much longer than monocrystal does. With monocrystal losing 50% of its strength after just a week, it is ideal for this application. I strongly prefer to use the SH tapered needle. The larger size of the needle when compared to other skin closure needles makes working around large bore sheaths much easier. For suture size, we tried using 2/0, 3/0, and 4/0 monocrystal sutures. While they all worked well, the 3/0 was the most commonly available on an SH needle and had enough strength for even higher tension closures. Both hand and instrument ties can be used for this closure, but if suture breakage is happening during closure, hand tying can allow for more accurate tension modulation. This is actually a clip from the first pulmonary embolism thrombectomy that I recorded, now over 5 years ago. I can tell that this is an early procedure because there is a 20 French gore dry seal sheath being used. I am using a monocrystal suture, but I am struggling for a couple of reasons. First, I am using a hemostat instead of a needle driver. Bad choice if you're trying to really grip the needle. Second, the needle looks tiny. If I had to guess, it looks like a PS2 instead of our normal SH. You can see how easy it can be to place these sutures, though, if you push and pull the sheath from side to side while placing the sutures to expose the incision. You can also see us holding much harder than is likely necessary in terms of the pressure between the movements. It really is a good demonstration of how our technique has evolved. In reality, at the end of the day, all of these techniques demonstrated here produce good outcomes when executed properly. The best technique for one provider is not going to be the best for everyone, but it is nice to know all of your options. If you found this helpful, consider dropping a like on this video to let me know. And if you have any thoughts of your own on this topic, specifically about large bore venous closure, let us know in the comments. Thanks.